Partha sir, hello, am I audible?
Yes, sir, you're very much audible.
Yeah, ये just आपको एक WhatsApp दृष्टि ने WhatsApp ग्रुप का रिक्वेस्ट भेजा है, जस्ट ज्वाइन.
As you said, 8 minute. WhatsApp group invite. Add. Sure. Join group. Yes, we've
Yeah.
joined the group. Yeah.
Okay, she will share this question, answer all these things, questions, that group only.
Uh, so we have uh, Professor Ganpati Bantwal sir with us today, and
I
we
already
also
joined.
yes sir. Sir, it's an honor to have you. Paksarthi,
Hi.
yes sir.
Oh, hi.
Sir,
I'll join with this one laptop. Okay, now.
sure sir, sure. It's an honor to have you as always, sir.
Thank you.
We also have Professor Sanjay Agarwal with us. Sir, it's an honor to have you too. So I'm Dr. Parthasarthi. I handle medical affairs for all the chronic therapy areas here at McLeod's. I also have my esteemed colleague, Dr. Anuja Jose, with me. Sir, you're not audible. I think you're muted, sir.
Okay, good evening. Now I
Good
think
evening, sir.
you are audible.
Yes, sir. So I think Professor Jabir is yet to join. So just a pre-meeting brief with you and Ganpati sir. You both are you all are stalwarts. I know Ganpati sir, professor. Personally, he's somebody I consider a teacher figure for me. So the meeting will start off with me introducing each and every one of you. We would hand over the session to Dr. Jabir. First, after Dr. Jabir, there would be Professor Ganpati sir, and then yourself. Post that, sir, we would have a quick panel discussion, and it would be more an audience Q&A that comes, because whatever questions and answers do come from the audience, we'll post it to you, sir, Professor Ganpati and Professor Jabir, depending on how the questions come. We end with a vote of thanks here from McLeod's, from Aaron, and we hope to wind up in time, sir.
Fine.
Thank you, sir.
Good evening, Dr. Sanjay.
Bantwal sir, greetings. Very good evening. Bantwal sir, very good evening. Am I audible, sir?
Yes,
I think
audible.
I'm not audible.
Here, no?
Ganpati sir, am I audible? Bantwal sir, am I audible?
Yeah, you are audible.
Thank you, sir. Thank you, sir. How are you, sir?
Fine, fine.
Sir, it's always an honor to have you. Thank you so much, sir.
Thank you.
I'll have the honor of introducing also Dr. Anuja Jose. She's joined the medical team of McLeod's very recently. And sir, we'll be glad to meet you whenever we come to Bangalore.
You can come.
So we are waiting for Professor Jabir, and we'll start off as soon as
He has joined.
he's joined. Yeah. Jabir sir, very good evening.
Good evening.
So very good evening. I'm Parthasarthi, Dr. Parthasarthi. I handle medical affairs for McLeod's Pharmaceuticals. Very glad to have you. Sir, we would start off in time. The format would be very simple. After the introduction, I would hand over to you as our first speaker, followed by Professor Bantwal sir. Finally, we'll have Professor Sanjay Agarwal sir, and after the discussion, we'll have a audience Q&A based on whatever the question and answers come, and we end in time with a vote of thanks. Thank you, sir.
Okay.
Yeah. So we ask our tech support, our technical experts now, if we can time a start. I believe it's 8:05.
Yes, we can start.
Start? Great. So when you give us the countdown, we start. Yeah.
One, two, three, start.
So very good evening, one and all. It's a pleasure to have you all gathered right now for an academic feast that is to follow. As you all might know, India is home to more than 315 million hypertensives as per the ICMR data. And we often discuss diabetes a lot, but we also have to understand other NCDs in the Indian scenario where hypertension actually has 3 times the incidence of diabetes. Also very common in the Indian scenario, as you all know, my dear doctors, is there tends to be a clustering of cardiovascular risk factors in the Indian population. The patient does not come to you just with hypertension. He comes to you with other associated disorders. Challenges, again, differ based on geography, based on patient education, based on are we truly treating patients to targets, and so on and so forth. So to delve more into a more 360-degree view of hypertension, we have today leading experts from different fields who can open our vistas to it. We'll be discussing it from the perspective of cardiology, from the perspective of endocrinology and metabolic health, and also from the perspective of nephrology. And to take the discussion ahead, we have a panel of experts of whom I have the honor of introducing. For the first talk, we have Professor Dr. Jabir Abdullah Kutisa, who, as you all know, is Senior Consultant and Director of Cardiology at Leslie Hospital, Cochin. He's assumed various leadership roles as Secretary of the CSI Kerala chapter, has also been Organizing Secretary of the National Intervention Council in the midterm meet in 2014, and has also served as an executive committee member in the Cardiology Society of India, is also the executive committee member of the CSI. Next, we have Professor Dr. Ganpati Bandwal sir, who, why has the slides? Yeah, I hope my slides are visible. Technical snacks, yeah. So next we have Professor Ganpati Bandwal sir, who needs no introduction in the field of medicine or endocrinology. And we all know him very fondly as one of the fantastic teachers in Indian forums. Sir is a reputed endocrinologist, as the professor and head of the department of St. John's, the Department of Endocrinology at St. John's Medical College and Hospital, Bengaluru. He has numerous publications in peer-reviewed national as well as international journals, and has also served as the past president of the Endocrine Society of India. He also has been a principal investigator for over 50 clinical trials and studies. Next, we have a distinguished teacher again in nephrology. We have Professor Sanjay Agarwal sir, who is Chairman, Nephrology and Kidney Transplant Medicine at Maringo Asia Hospital, Gurugram. Sir has over 42 years of extensive experience across various cities in India, was the former head of nephrology and professor at AIIMS, New Delhi, has been a key contributor to governmental policies on CKD, kidney transplantation, and multiple other areas of interest in nephrology, with performing over 5,000 renal transplant and 25,000 kidney biopsies. I now hand over the session to our first speaker, Professor Jabir sir. Sir, over to you.
Thank you. Thank you, Dr. Parthasarathi. Is my slides visible?
Yes, sir.
Okay, thank you. Good evening. I'll be discussing regarding some basic things about hypertension, since there has been the newly released guidelines of European Society of Cardiology guidelines of hypertension some 2 weeks ago in their London meeting. So there are certain conceptual changes, and then I'll be discussing regarding the role of cilnidipine and hypertension. So if you look at the hypertension in India, at least 1 in 10, if you look at the screened persons, it's a huge data from the analysis of National Family Health Survey. Quite recent, 2019 to 2021, large number of patients over 3 lakhs. You can see the awareness of hypertension is there only in 1/3. The treatment is close to 14% and under control is close to 8%. So that's the problem in India. We don't have awareness. People are not taking treatment despite the large number of hypertensives among the Indian population who are at high risk, because ethnically we are at high risk of developing cardiovascular disease at a younger age group, very bad disease, complex disease with high morbidity and mortality. And the most important risk factor for coronary artery disease, stroke, heart failure, and renal disease, the control is only in 8%, which is one of the most important treatable things. So we need much more things to be done at the level of the public health aspect to improve these things. So out of office blood pressure measurement has gained a significant importance in the diagnosis as well as management of hypertension. We have 2 out of office blood pressure measurements, either a home-based blood pressure measurement or ambulatory blood pressure measurement. The home-based, you have to use a validated BP device and measure the blood pressure in a quiet room after 5 minutes of rest with the arm and the back supported. And hypertension is the average home blood pressure monitoring of more than 135/85. Now, each occasion you have to take 2 blood pressure measurements at 1 to 2 minutes apart. At least twice a day to take the blood pressure measurements, 1 in the morning and 1 in the evening for at least 3 days, and preferably for 7 days a week. And the ambulatory blood pressure monitoring, this device usually records the blood pressure at 50 to 30 minutes intervals during the day and 30 to 60 intervals, 60 minutes intervals at night. It's an excellent thing to diagnose a white coat hypertension, a master hypertension, and also the control of hypertension. For example, resistant hypertensions may be pseudo-resistance. When they come to the clinic and office blood pressure measurement may be high, but at the same time, when you look at the ambulatory blood pressure monitoring, it may be fully controlled because of the white coat effect. And in any ambulatory blood pressure monitoring, there should be a minimum of 70% usable BP recordings. And the hypertension definition, the new definition to 2024 by the US is ambulatory blood pressure monitoring over 24 hours should be more than 130/80. Daytime average 135/85 and nighttime average 120/70 millimeters of mercury. And now, the previous ESC definitions, if you remember, it was like the optimal blood pressure, borderline blood pressure, then the stages of blood pressure. Now they have divided it into 1, a non-elevated blood pressure. Anything less than 120/70 office blood pressure. For that matter, it is office blood pressure, home blood pressure, daytime ambulatory blood pressure. It is same. Less than 120/70 is non-elevated blood pressure. That is a new terminology that has come into the field of hypertension. And for 24 hours, it is less than 115/65. And nighttime, it is 110/60 millimeters of mercury in an ambulatory blood pressure monitoring. Elevated blood pressure 120 to 139 and 70 to 89. So the home blood pressure monitoring, it is 120 to 135 and 70 to 85. Ambulatory blood pressure monitoring, daytime it is same, and 24 hours it is 5 millimeter less, 115 to 130 and 65 to 80. And nighttime blood pressure, it is 110/60 to 120/70. Anything more than 140/90 in office blood pressure is hypertension. Home blood pressure 135/85. Daytime ambulatory blood pressure same. 24-hour ambulatory blood pressure monitoring 130/80, and night it is more than 120/75. So the BP is categorized now as non-elevated blood pressure, elevated blood pressure, and hypertension. This is to aid treatment decisions. Now it's a class 1 recommendation. So I think if you look at the non-elevated blood pressure, insufficient evidence confirming the efficacy and safety of BP pharmacological treatment. There is no indication of pharmacological treatment at this blood pressure level. Elevated blood pressure, that is up to 139 or diastolic up to 89, you have to risk stratify these patients to identify those individuals with high cardiovascular risk for blood pressure pharmacological control. More than 140 over 90 confirmed. Here, the cardiovascular risk is sufficiently high to merit pharmacological treatment initiation. So, the risk factors highest risk, established clinical cardiovascular disease. MI, a patient who had MI, revascularization, or coronary angiographically proven coronary artery disease, or heart failure. Moderate to severe CKD. And hypertension mediated organ damage like left ventricular hypertrophy, heart failure, left ventricular enlargement, or aortic aneurysm, peripheral arterial disease, stroke. Diabetes mellitus, type 1 and type 2 diabetes mellitus. FH, familial hypercholesterolemia, probable or definite familial hypercholesterolemia. These are all high risk factors. So patients with heart failure, established coronary artery disease, CKD, diabetes, hypertension mediated organ damage, and familial hypercholesterolemia. So once you screen the patient by office blood pressure, non-elevated blood pressure, more than 40 years, to screen them. If it is younger patient, once in 3 years, opportunistic BP screening. More than 40 years, every year you have to check the blood pressure. Elevated blood pressure, look for high cardiovascular disease conditions or risk stratify. The Europeans risk stratify them using the score risk with diabetic patients or the score to diabetes risk or the risk modifiers. Confirm the blood pressure, preferably with either home or ambulatory blood pressure measurement. Hypertension, again, is confirmed. If the blood pressure is high, 160 to 179 or 100 to 109. Confirm with either home or ambulatory blood pressure monitoring quite early. And more than 180 over 100, you have to immediately evaluate for a hypertensive emergency situation. The initial workup, what is required is a fasting blood sugar, lipid profile, the renal function test, electrolytes, hemoglobin, calcium, thyroid stimulating hormone, the creatinine, EGFR, urine, albumin, creatinine ratio, that is very important. A 12-lead electrocardiogram. The optional tests are echocardiography, cardiac CT when it is to assess the hypertension-mediated organ damage, or a carotid or femoral arterial ultrasound imaging to look for the atherosclerotic plaque. Then look for the large artery thickness, pulse wave velocity, high sensitivity cardiotropony or NT-proBNP. That's also to assess the hypertension-mediated organ damage. Angle brachial index, abdominal ultrasound, fundoscopy. Fundoscopy, I think, is a basic investigation which is required. Echocardiography in most of the patients, because it's not like Europe or America where it is difficult to get an echocardiography done, but here echo is widely available. You can get an echocardiography done. That's important. So what are the basic lifestyle modifications? Increase the potassium intake, increase physical activity, optimize the management of diet and weight, reduce the table salt intake. The sodium chloride intake should be reduced to less than 5 grams a day. Reduce the alcohol intake. Maximum should be in a week, it should be 100 grams. 100 grams means it's 10 drinks a week. One drink is close to 10 to 14 grams and absolutely no smoking. Regarding the exercise, aerobic exercise training at least 150 minutes a week or high intensity training 75 minutes a week. And increase the daily physical activity, avoid the sedentary lifestyle. And now it is said that if possible, your regular exercise schedule should have 2 to 3 days of resistance training, low to moderate intensity, like 3 sets of 1 to 2 minutes of hand grip, plank, wall sit, something like that. Or dynamic or isometric resistance exercise to complement aerobic exercise training 3 times a week. And this should involve the large muscle groups, 2 to 3 sets with a squat, push-up, or sit-up. So the concept of exercise is also changed. Initial monotherapy, elevated BP category, moderate to severe frailty, symptomatic orthostatic hypotension, or very elderly, more than 85 years. Otherwise, it's always a low dose double combination therapy using ACE, ARB, calcium channel blocker, diuretic. Follow up at least every year. And if the BP is controlled after 1 to 3 months, assessment is at 1 month preferred if possible. Low dose, if not controlled, low dose triple combination therapy. If not controlled after 3 months, maximum tolerated dose of the triple dose combination therapy. And if controlled after 1 month, it's fine. Follow up regularly at 1 year. If not, it's likely to be a resistant hypertension. You may have to refer the patient to a hypertension clinic. Look for adherence. Add spironolactone. And beta blocker is a drug which can be added at any step. And also, if there are accompanying indications like in between, if he develops ACS, heart failure, or especially for the hypertension, this is heart rate control. So screening for hypertension, opportunistic every 3 years to less than 4 years. In those patients with less than 40 years and more than 40 years every year. Confirm the hypertension with out-of-office blood pressure measurement. Non-elevated blood pressure, lifestyle measures, and screen every 3 years if it is younger patients, once in a year if it is older patients. Elevated blood pressure, severe age, very elderly or frailty or symptomatic orthostatic hypertension, short-term life expectancy, only lifestyle modification. Established CVD, moderate to severe CKD, hypertension mediator organ damage, diabetes, familial hypercholesteremia. If it is yes, lifestyle measure, confirm blood pressure, more than 130/80 with lifestyle modification. If it persists, you go for a pharmacological treatment targeting the systolic blood pressure, 120 to 129, and diastolic blood pressure 70 to 79. Hypertension, dose, resistant hypertension, if there are resistant hypertension features, especially in those patients, younger patients presenting with high blood pressure, target organ damage, screen for the secondary hypertension. If there is secondary hypertension, targeted therapy. If not, lifestyle measures, confirm blood pressure, persistent medications. Okay, so these are the new concept that has come up in the latest guidelines. So I'll move on to the calcium channel blockers. So calcium channels, we have the L-type calcium channels, the N-type and the L-type. The L-type calcium channel blocking will lead on to potent vasodilation, the older drugs, nifedipine, felodipine. So all the CCDs have effect on L-type calcium channel blockers. Some of them may inhibit the N-type calcium channel blockers, which decreases the norepinephrine release in the sympathetic nerve ending, predominantly the cilnidipine group. And the T-type, which improves the renal microcirculation, that is the eponiptine and cilnidipine. So if you look at the cilnidipine, which is one of the most widely used, the 4th generation calcium channel blocker, it blocks the L-type calcium channel blocker, potent vasorelaxation. It blocks the N-type calcium channels and reduces the norepinephrine release. So produces additional vasorelaxation, reduction of elevated heart rate, and decrease elevated activity of the renin-angiotensin-aldosterone system. It reduces or it relaxes the arterioles, afferent, and also it may relaxes the venules. And this venular dilatation is to the blockage of N-type calcium channel. So this decreases the capillary pressure and reduces the oozing of the fluid into the interstitium and may not cause as much fevered as potent vasodilator like amlodipine. So if you look at the effect of cilnidipine, you can see that the home blood pressure monitoring from 146 after 8 weeks to 134, 88 to 82. And the home blood pressure measurement, you can see from 150 to 131, 95 to 83. And the pulse rate also, you can see there is a reduction in the pulse rate. So 2-digit reduction in the blood pressure, systolic blood pressure is possible. And if you look at the proteinuria, comparing amlodipine and cilnidipine, there's a significant reduction in the proteinuria at 12 months. So the promise of cilnidipine in hypertension with comorbidities, this is the national consensus statement published in JAPI in 2022. The benefits of cilnidipine due to its N-channel blocking potential have been well documented in the Achieve-1, Carter, Stroke, CA-ATTENT, and the CA-ATTENT subset. This is a 4th generation calcium channel blocker, which can block both the N and the L-type calcium channel, thus having improved benefits than the older calcium channel blockers. This offers a smooth and a sustained control of 24-hour blood pressure control, including if you look into the out-of-office blood pressure measurements. Cilnidipine in the studies have shown that it reduces nocturnal blood pressure, improves the nocturnal dipping, and have beneficial effects on morning and nocturnal hypertension. And these beneficial effects are due to its sympathologic activities due to the N-channel blockade. It does not cause reflex tachycardia, which may be due to the improved baroreflex sensitivity and reduction in the sympathetic nervous system activity. It decreases proteinuria that is not there for other calcium channel blockers by decreasing the intraglomerular pressure, dilates the efferent arterioles, it dilates the venules also, and has antioxidative properties, inhibits the renal RAS, and suppresses the podocyte injuries. Cilnidipine causes minimal pedal edema. This is less than 2% versus amlodipine, which produces pedal edema close to 11% of Indian patients. It's a lipophilic molecule, high volume of distribution, and hence has been shown in studies to have a 24-hour action. So even a single dose is sufficient. We can give it as a monotherapy, single day dosage. Its half-life is close to 7.4 hours. Usual dose is 5 to 10 milligram daily, and the maximum dosage is 20 milligram per day. It improves cerebral blood flow and is shown to be beneficial in hypertension management in post-stroke patients and reduces the carotid intermediate thickness. Along with telmisartan, it's a good choice of combination therapy in patients with essential hypertension and diabetic hypertension. So I must conclude with these take-home messages. India needs more emphasis on awareness, detection, and treatment of hypertension, since we are ethnically a high-risk group for cardiovascular disease at an young age. The low-dose combination therapy is the rule to initiate treatment now, and cilnidipine with angiotensin receptor blocker is an excellent antihypertensive combination therapy to begin with in all patients. Nephroprotection and better tolerability make cilnidipine a first-choice agent among calcium channel blockers in the management of hypertension. Thank you so much.
Thank you so much, sir. We now request Professor Gadpati Bantwal, sir, and hand over the session to him. Professor Bantwal, over to you, sir.
Thank you, Parthasarthi. I think we should be closed the presentation. Dr. Jabir sir, you have to close the presentation.
Jabir sir, if you can unshare the presentation.
Right. Okay.
Yes.
Sir.
Able to see, no?
Yes,
Yes, sir. Yes, sir.
Fine, yeah. Dr. Jabir gave an overview of how to screen for hypertension, what are the targets, so all these things. Now I'll speak on hypertension in diabetes. So this is a growing menace. Globally also, this problem is happening. According to the latest ICMR INDIAB, we have around 101 million people with diabetes. And by 2040, diabetes will be prevalent in 10% of the world's population, and approximately 50% will be in Southeast Asia. And you can see that patients of diabetes with hypertension is around 56 million, which is around 73%. And in India, patients of hypertension is 250 million, and 1 in 2 patients with diabetes also suffer from hypertension. So hypertension is twice as frequent in patients with diabetes compared with those who do not have diabetes. So there was a study known as a SITE study involving 15,000 patients. Around 20% had both diabetes and hypertension. So what was the gist of the study was patients with diabetes have hypertension, around 60% have it. And patients with around 45% of patients with hypertension have diabetes. So there's a tremendous rise in the coexistence of diabetes and hypertension, which has been found in India. So they have the shared pathophysiology. You can see type 2 diabetic patients are 2.5 times as likely to develop in subjects with hypertension as in subjects with normal blood pressure. And the prevalence of hypertension in the diabetic population is around 2 to 3-fold higher than that of non-diabetic age-matched groups. Now, why are we concerned? Because it can lead to a lot of problems. So it can lead to atherosclerosis, along with, of course, hypertension with the combination, endothelial dysfunction, vascular inflammation, fibrosis, arterial remodeling. All these things can worsen micro and macrovascular disease and lead to cardiovascular disease. The excess cardiovascular risk in diabetes is attributed to coexistent hypertension. So you can see here, the all-cause mortality plus 72%, and the cardiovascular disease is because of this excess risk is because of associated hypertension. You can see blood pressure as a surrogate for CV outcomes in diabetes. So you can see the UKPDS study. Diabetes-related death because of blood pressure was 32%. Cardiovascular mortality in the HOT study 60%. Total mortality in the CIST Europe study was 64%. In the CAP study 46%, and in the HOPE 37%. And what's very important is only 1 out of the 2 patients with hypertension with diabetes achieve the BP control. 44% of the patients remain uncontrolled despite antihypertensive treatment. And patients are 7 times more likely to remain uncontrolled due to non-adherence to medications. Now, what is the link between diabetes and hypertension? So you can see insulin resistance and insulin deficiency leads to diabetes. Diabetes in turn can lead to arterial stiffness and can involve the kidneys, RAS activation, and produce hypertension. Hypertension in turn can produce microvascular damage, can increase sympathetic nervous system activity, which can further once again worsen the insulin resistance. So there is a, you can say, a dual link. So one leading to worsening is a vicious cycle, you can say, which can happen with this. Now, coming to recommendations, blood pressure should be screened at every routine diabetes visit. Patient found to have systolic more than 140 and diastolic more than 90 should have a blood pressure confirmed on a separate day. So what are the goals for individuals with diabetes and hypertension at higher cardiovascular risk? What do you mean by that? Existing ASCVD or a 10-year ASCVD risk more than 15%. The target should be less than 130 millimeters, 130 by 80. And who have a lesser than that, 10-year ASCVD risk less than 15%, treat to a target of less than 140/90. And this is a level A evidence. How do you treat these patients? Patients with blood pressure 120/80 should be advised lifestyle changes. More than 140/90 should, in addition to lifestyle therapy, you should start pharmacological treatment. Coming to non-pharmacological management, weight loss, very important. 1 kg of weight loss, 1 millimeter of mercury comes down. Sodium restriction, less than 2.3 grams. You can see a reduction of 5 millimeters of mercury systolic and 2 to 3 millimeters of mercury diastolic. Exercise. Diabetic patients who are 35 years of age or older and planning to begin a vigorous exercise program should have exercise stress testing or other appropriate non-invasive testing. And as Dr. Jabir told, at least 150 minutes of moderate intensity aerobic physical activity is recommended per week. And of course, 20 minutes of anaerobic weeks at least 3 times a week is required. Smoking cessation and moderation of alcohol intake. Now, coming to the effects of weight loss and blood pressure from the look-ahead trial, you can see in the first year it came down by at least around 7 millimeters systolic and around 3 millimeters diastolic, and which was maintained. Individuals with confirmed office-based blood pressure more than 150/90, in addition to lifestyle, should have prompt initiation and timely titration of 2 drugs or a single pill combination of drugs. So that is a fixed dose combination you can use. And when you do this, it has been found to reduce cardiovascular events in people with diabetes, and this is a level A evidence. In general, you can see from the various trials, you require multiple drugs to achieve blood pressure control in patients with diabetes. Sometimes you can find that these patients can have resistant hypertension. That is, when you say resistance, who are not meeting blood pressure targets on 3 classes of antihypertensive medication, including a diuretic, should be considered for mineralocorticoid receptor antagonist therapy. Pregnancy, the target is less than 135/85. Now, this is based on the CHIPS trial in the interest of optimizing long-term maternal health and minimizing impaired fetal growth, and this is an expert opinion. What about the HOT trial? You can see the major CV events reduced by 51% in patients with diabetes, and you can see a 67% reduction in CV deaths in patients with diabetes. What about UKPDS? So here there are 2 groups. So you can see a 13% decrease in microvascular complications per 10 millimeter reduction in systolic blood pressure, and a 12% decrease in myocardial infarction per 10 millimeter reduction in systolic blood pressure. And you can see there were 2 arms. The intensive arm had a blood pressure of 144/82 and the conventional 154/87. So the intensive arm, myocardial infarction, 21% reduction. Any diabetes-related endpoint, 24% related endpoint reduction. Diabetes-related death, 32%. Stroke, 44%. Heart failure, 56%. Renal failure, 42%. Retinopathy, 34%. Visual deterioration, 47% reduction. We had the ACCORD trial. In the ACCORD BP arm, actually they didn't find much benefit. So one group, they wanted to achieve less than 120, the intensive arm, and the other group less than 140. So they didn't find, they found it was the same, except in the subgroup who had, in the intensive arm, they found stroke was reduced. So otherwise, they didn't find any benefits. So what is the ADA recommendation for that? So the recommendation is initial BP more than 140/90 or less than 160, start 1 agent. And if he has albuminuria, start ACE or ARB. So this is mandatory. If it does not have albuminuria, you could start with ACE, ARB, CCB, or a diuretic. Of course, lifestyle management should be a part of this. If it is more than 160/90, now they say more than 150/90, you could start 2 agents. And if albuminuria is there, either ACE or ARB and CCB or diuretic. No albuminuria, you could use either ACE, CCB, or a diuretic. If you're achieved control, good. If you're not meeting the target, you add an additional drug. And in spite of 3 drugs, which includes a diuretic, if you're still not reaching the target, add a mineralocorticoid receptor antagonist also. Well, I won't go into this. This has already been covered by Dr. Jabir. So what are the types of the calcium channels? He has already. Just to tell, 3 types of calcium channel blockers. One is the phenylalkylamines, where you have the verapamil, benzodiazepines, which is diltiazem, dihydropyridine. First generation was nifedipine, second generation isradipine, nicardipine, felodipine, third generation amlodipine, and cilnidipine is the 4th generation dihydropyridine. Some studies about that. So a study from Japan, renoprotective and antioxidant effects of cilnidipine in hypertensive patients. So what they found here was they compared cilnidipine with amlodipine. Systolic blood pressure reduced in amlodipine to the tune of 23, And in cilnidipine, 21 millimeters of mercury, diastolic 12.5 versus 10. But if you see, pedal edema was lesser in the cilnidipine group. They also measured urinary albumin, 8-hydroxy-2-deoxyguanosine, and the liver type fatty acid binding protein to creatinine ratios. They were significantly decreased in the cilnidipine group compared with those in the amlodipine group. And this reduction in the antioxidants, etc., were not correlated with the change in the systolic. So it was an independent effect. So you can see the edema was very minimal with the cilnidipine. Another study, once again, where they found this is a Carter study. So 350, 339 randomized, 179 received cilnidipine, 160 amlodipine, 147 completed study in the cilnidipine arm and 130 in the thing. Blood pressure reduction, systolic, diastolic was the same in both the arms. But what you can see is the urinary protein creatinine ratio was actually better in the cilnidipine. You can see on the right-hand side. There was a reduction in proteinuria, percentage reduction, up to even 20% reduction compared to amlodipine, where there was actually no, on the contrary, there was slight increase also. And this did not differ whether you had age more than 65 or less than 65, male or female, blood pressure less than 130/85 or more than 130/85, whether you had a nephropathy, primary renal disease, or hypertension, whatever it is, they found cilnidipine continued to show reduction in proteinuria. Adverse events were the same in both the groups. So 20 in the cilnidipine and 19 in the thing. So my take-home message is excess cardiovascular risk in diabetes is attributable to coexistent hypertension. Hypertension is difficult to control in patients with diabetes due to clinical conditions such as volume overload, change in RAS activity, and central sympathetic hyperactivity. Multiple drugs will be needed in general to control the hypertension, especially the ACE or ARBs, diuretics, CCBs like amlodipine and cilnidipine. Resistant hypertension, in addition to above, will require addition of mineralocorticoid receptor antagonist. Thank you for patient hearing.
Thank you, sir, for that wonderful oration. We now hand over to Professor Agarwal for his next talk. Sir, over to you. Professor Agarwal, sir, over to you, sir.
Yeah, is my slide visible?
No, sir, it's not.
It's visible.
It should be visible.
It's visible now, doctor.
Okay. So what I am going to cover is I will give more of a concept of renal protection in addition to blood pressure control. My work has been made much easy by Dr. Jabir and Dr. Ganpati. So I may be little fast to save some time also. This slide has been shown by Dr. Jabir. I will not go further. Now, what is the glomerular filtration depend upon? One of the major factor is hydrostatic pressure in the glomerulus, which is guided by the systemic blood pressure, which is hypertension. So any drug which decreases intraglomerular filtration pressure is going to be protective for the kidney on a long-term basis, in addition to the control of blood pressure. Now, this is a little complex slide, but just to make it simple, any drug which causes, any drug or factor which causes vasodilatation of the afferent arteriole, any drug or factor which decreases the tubuloglomerular feedback, which indirectly causes afferent arteriole effect, vasoconstriction of the efferent arteriole, increased sodium chloride absorption. All these factors actually increases the intraglomerular hypertension, and any drug which decreases any one of these four mechanisms will decrease the intraglomerular pressure, and on a long term will prevent the glomerulosclerosis and deterioration of the renal function. And these all drugs which have a specific factor on one of these four mechanisms will be beneficial in addition to control of the blood pressure. Now, in terms of afferent and efferent arteriole, the dilatation of the afferent arteriole and the constriction of the efferent arteriole, these two mechanisms increases glomerular intraglomerular pressure and increases filtration. In presence of a chronic kidney disease, there is a auto-regulation as such in a normal population that with increase in the systemic blood pressure, there is a control of passing of the systemic blood pressure to the intraglomerular pressure. But in presence of a kidney disease, this mechanism is affected and the systemic blood pressure is in absence of a poor auto-regulation, systemic blood pressure is passed on to intraglomerular pressure and has got a deleterious effect on a long-term progression of chronic kidney disease. It is also important to understand that blood pressure is not only cause of renal damage, but it is also can be effect of the kidney disease. And hypertension causes hypertensive nephrosclerosis through intraglomerular pressure increase and then alteration in the inflammatory profile. And this ultimately leads to glomerulosclerosis, which on a long term causes chronic kidney disease. And chronic kidney disease, once it progresses with time from stage 1 to stage 5, increases the degree of blood pressure by two major mechanisms, either increase in the renin secretion or increase in the water and salt retention. If you see the causes of chronic kidney disease, hypertension constitutes approximately 20% of all cases of chronic kidney disease. There is another very peculiar thing in relation to kidney disease, which is not there in any other organ, that once the critical mass of the kidney is damaged, there is an extra load to the remaining nephron, and that causes further kidney damage, and this cycle goes on and on till the patient reaches to the end stage kidney disease when the patient needs dialysis or transplantation. Now, the key mechanism of this cycle is hyperfiltration, which is increase in intraglomerular pressure of the single nephron. So again, coming back to any drug which decreases the intraglomerular pressure will be helpful in retarding the progression of chronic kidney disease. Now, chronic kidney disease, leaving behind other factors which I will not cover, degree of systemic blood pressure, hyperfiltration, and the degree of proteinuria. These are the three factors which are key factors for progression of the chronic kidney disease. Now, proteinuria and hyperfiltration goes parallel. More is the intraglomerular pressure, more is the filtration of the protein, and excess protein filtration and increase in intraglomerular pressure will lead to glomerulosclerosis and progression of the chronic kidney disease. And because there is a loss of autoregulation, the systemic hypertension is actually passed on to the glomerulus level and increases the intraglomerular pressure. It is very clearly shown that the chronic kidney disease patient who are normotensive has got slower progression of renal function as compared to patient of chronic kidney disease who are hypertensive. Once we are treating the chronic kidney disease, there are three major factors in relation to hypertension. One is control of systemic blood pressure as such. Second is decrease in intraglomerular pressure, which indirectly also decreases the degree of proteinuria. So any drug which which controls the systemic blood pressure, but also in addition decreases the intraglomerular pressure and thereby decreases the degree of proteinuria, will be beneficial for progression of chronic kidney disease in addition to control of blood pressure. Another important thing which is good to know that if you follow 100 patients of chronic kidney disease, a large number of a patient actually die of a cardiovascular death before reaching to end stage renal disease. which means that while you are treating hypertension in chronic kidney disease, any drug which, in addition to control of blood pressure and is also cardioprotective, will be preferable to the antihypertensive drug which are not cardioprotective. All these management, whether decrease in intraglomerular pressure, systemic hypertension control, and decrease in degree of proteinuria, needs to be started with the early stage of chronic kidney disease, because if we do that, we can delay the progression of early stage of chronic kidney disease to end stage kidney disease when the patient needs dialysis or transplantation. Now, target has already been discussed by the previous speaker. What KDIGO 2020 says that in terms of a treatment, patient who are diabetic kidney disease, patient with chronic kidney disease with albuminuria more than 300 milligram per day, irrespective of the degree of GFR, should be started on RAS inhibitor, which is ACE inhibitor or receptor blocker. There are three strategies in management of hypertension with chronic kidney disease. Either maximize the single drug before adding the second drug, or add a second drug before maximizing the first drug, or start two medications who are separately acting on the two arms of the control of blood pressure. Now, these things has also been discussed by previous speaker. This is a summary slide that the initial start of the therapy should be with ACE inhibitor or receptor blocker, with calcium channel blocker or diuretic. And if the blood pressure is not controlled, then the triple drug combination needs to be initiated. And if with the triple drug combination also blood pressure is not controlled, then mineralocorticoid receptor blocker or beta blocker or other alpha blocker drugs can be used. Beta blocker in these approach can be added depending on the specific indication of the heart failure, angina or post-MI. And in addition to dual combination, single drug therapy can be added if there is a very mild hypertension. But in chronic kidney disease patient, a majority of patients need at least two drugs even in a mild chronic kidney disease. Coming to the comparison of different class of agent, if you concentrate on the lowermost row, which is renal protection in terms of microalbuminuria, the drug ACE inhibitor, receptor blocker, and calcium channel blocker, these are the three major drugs, class of drug which decreases the degree of proteinuria, because these also decreases the intraglomerular pressure. Now, this slide has been shown by the previous speaker. In terms of a calcium channel blocker, dihydropyridine group has got 4 generations. This is also covered by the previous speaker. In cilindipine, if you see the renal protection, the maximum effect of renal protection is with 4th generation cilindipine as compared to 1st, 2nd, and 3rd generation of dihydropyridine group of the drugs. Now, if you compare head-to-head with telmisartan and cilindipine, probably both are equally effective and control the systolic as well as diastolic ambulatory blood pressure. While we are using antihypertensive drug in CKD patient, we need to remember the major side effect. And while comparing the ACE inhibitor receptor blocker against cilindipine, or the dihydropyridine calcium channel blocker, ACE inhibitor and receptor blocker causes hyperkalemia and cough is much more with ACE inhibitor. That is why most of nephrologists actually, out of these two drugs, use angiotensin receptor blocker as a RAS inhibitor. And as has been mentioned that out of various dihydropyridine calcium channel blockers, cilindipine has got very minimal fetal edema as compared to other drugs. So, what is the usual line of treatment? ACE inhibitor or receptor blocker with or without calcium channel blocker and with and without thiazide diuretic, Depending upon the strategies and while monitoring the patient, if the blood pressure is not controlled with this, then mineralocorticoid receptor antagonist can be added as a fourth drug for severe hypertension. I will end my talk by take-home message that hypertension is cause as well as effect of chronic kidney disease. It is one of the most important risk factors for progression of chronic kidney disease. Presence of CKD is a risk equivalent of cardiovascular disease. The sizable number of a CKD patient actually die of a cardiovascular death before reaching to end-stage kidney disease. So any drug which control the antihypertensive drug should get the BP control to the target, but still it needs to be individualized depending upon the side effect and the degree of control of blood pressure. Antihypertensive drug which decreases intraglomerular pressure and proteinuria is preferable because of the additional benefit of the renal protection. Antihypertensive drug which is also cardioprotective is preferably as compared to drug which does not protect heart, because a large number of patients die of a cardiovascular death before reaching to end-stage renal disease. Thank you for your kind attention. And
Thank you so much for your wonderful talk, sir. Uh, what we've had is three experts speak on hypertension from the cardiovascular perspective, from the endocrine perspective, especially the diabetes perspective, and from the nephrological perspective. With the permission of our esteemed speakers, if we can proceed ahead with the audience Q&A in the interest of time. Dear
Yes.
sirs.
Sure.
Thank you, sir. So the first question is to Professor Jabir, sir. Jabir, sir, are you there, sir? Professor Jabir? Okay. So probably a technical issue in connecting. So until sir comes, sir, the next question is to Professor Bantwal, sir. So the question is hypertension and diabetes. What are your key clinical takeaways when you manage these patients, and what is the place of the newer anti-diabetic medications in these patients?
So number one, as Dr. Sanjay Agarwal told the same thing, I agree with him. I will use more often ARBs than ACE inhibitors, because we don't want that cough to come. It's seen in up to 20-25% of our patients. So we begin with a single agent, as I told you, if it is more than 140/90, but if it's more than 150, we add actually a diuretic. So nowadays we prefer chlorthalidone actually. One of the reasons being when I add these two combination, the effect is very good. See, as you know, these drugs act best when you have a high renin activity. PRA is high. That's the time when it acts best. The moment you add a chlorthalidone, what happens is you have volume depleted, the renin activity increases, and the blood pressure control becomes tremendous. So that's the reason we do that. The next step will be adding a CCB, because that's also a very powerful agent. So that's how we go about. And of course, once you are done with this, any patient, drug, we'll actually start, and especially if the potassium is coming on the lower side, we work up for cons in majority of them. Yeah, now the role of anti-diabetic drugs. Yes, SGLT2 inhibitors, without any doubt, yes, they do play a role. It can reduce blood pressure by 5 millimeters systolic and maybe 2 to 3 millimeters diastolic. But then we are not using it as an anti-hypertensive as of now, as it's only as an anti-diabetic, which can reduce proteinuria for heart failure, all these things. So we are using it, but not as an anti-hypertensive agent per se. GLP-1 also has effects. They also reduce systolic and diastolic blood pressure, maybe independently and also because of this weight lowering property also.
Thank you, sir. Wonderful. So well summarized.
may I come in on this issue?
Yes, sir.
Absolutely, sir. Absolutely.
Yeah, actually, SGLT2 inhibitor also decreases potassium. And with SGLT2 inhibitor, we can use maximum tolerable dose of ACE inhibitor
Yes,
or
sorry, ARBs. Yes, correct.
which is one of the most important factor for controlling the blood pressure, both in diabetic and non-diabetic CKD.
Sure, sir. Thank you so much. So wonderful always to have these aspects. And so the next question we take is for Dr. Jabir. Jabir sir, the question is how relevant is the new normal, the ESC new normal of 120/70 in the Indian scenario, especially in a country where uh, achieving target BP of less than 130/80 is a challenge. Your take on the same, sir.
I'll tell you, achieving a target or to make the patients to take drugs, to what do you call, to promote them to take drugs itself is difficult. I think it is, it's only a dream to have blood pressure below 120/70. I think it is practically impossible. If we can keep the blood pressure sustained below 140/90 in an Indian patient, that is the best goal. That is achievable. What is your opinion? Very severe.
Yes, I think I agree with you because they'll tell, no, I don't want to take tablets. You are drugging me, they'll tell. So that's a problem.
And the dropouts, if you look at 1 year dropout rate, it will be more than 40% in Indian population. It's not that easy to keep it at 120 millimeters of mercury or a target of 120 to 29.
In fact, they'll tell if it is below 70, they'll tell I'm having low BP and they'll
Low
stop it.
BP.
They'll stop.
True. True. Very true. The next question for Sanjay Agarwal, sir. So something similar. I mean, this was one spectrum, 120/70 from the perspective of definitions. We come to the other spectrum in the Indian scenario, which we commonly see in hospital practice. So in India, not being uncommon where a patient directly comes with evidence of hypertension-mediated organ damage. Let us say this person is coming to the hospital with evidence of chronic kidney disease and probably stage 4 or stage 5 chronic kidney disease with an event that is coming to the hospital. And now we want to know if hypertension is the cause of CKD or hypertension is the effect of CKD. Becomes a big question mark. So your takeaways of the same, sir. When should we consider as hypertension probably a cause or hypertension is probably as an effect? And your takeaways into managing these patients.
No, you see, it is very difficult in Indian scenario because most of the time we do not have a past history or the record of investigation of the patient in the past. Say things which can very clearly direct whether it is cause or effect. Say somebody with a very mild hypertension and has got nephrotic range proteinuria, chances is much more that it is primary kidney disease and the hypertension is the effect of kidney disease. Second thing is that if with the control of primary kidney disease, if hypertension get controlled without any drug, then also we know that the hypertension was because of the kidney disease rather than hypertension was primary cause for kidney disease. Long-standing hypertension, effect of target involvement in terms of a hypertensive retinopathy, in terms of a left ventricular hypertrophy, and still a very mild proteinuria and stage 1 or stage 2 chronic kidney disease is more likely of a hypertension as a primary cause and causing mild renal involvement, which is secondary. So these are the factors which, but the most important factor, if we have got a past history clearly mentioned, that patient was hypertensive and there was no decrease in the GFR and no proteinuria, and the later on we find that increase in serum creatinine or start of proteinuria, then we know the time effect relationship that patient started with hypertension without any renal involvement and now started having renal involvement. But I can tell you, it is very difficult to sometime to be sure that whether hypertension was cause or the effect. But what I will tell in the end that it will probably does not matter at that stage when the patient comes to us in a clinic, because most of the patients come in the clinic in stage 3 or 4 chronic kidney disease. Stage 1 and 2 chronic kidney disease is only detected once, either in a diabetic clinic where patient is being followed up long-standing diabetes, or it is done by for insurance purposes, or it is done by radiology contrast radiology investigation, or pre-operatively. Otherwise, most of the time we detect patient for the first time in stage 3 and 4 chronic kidney disease, and that time it is control of blood pressure with the drug which decreases intraglomerular hypertension. These factors are much more important rather than trying to label which one was the cause or which was the effect.
So much, sir. Thank you so much for that. So wonderfully put forth. So what is the cause or what is the effect? Doesn't matter. Which came first, the chicken or the egg, again, is secondary, but treating the condition matters. Thank you, sir. Very good takeaway message for our audience. A quick question to Bandwal, sir, from one of our audience. So secondary hypertension evaluation from an endocrinologist perspective, what are the things that should be thought of?
Well, I would say the commonest is actually you'll have to look for hyperaldosteronism. Because initially, Jerome Cohen, when he actually diagnosed it, he told so-called essential hypertension, 20% is because of that. But then it was criticized, and then later on they told, no, it's around 5%. But once again, they have revised it. Now it's around 10 to 15%. In the resistant hypertension clinic, in fact, 30% of the resistant hypertension are because of cons. So cons is the most important thing. You'll have to work up for that. PSC, PRA, we'll have to do for that. That's one. The other thing, most commonest, another one is actually obstructive sleep apnea. Resistant hypertension, you look for obstructive sleep apnea. And of course, renal involvement also is another cause. So these are the two things which we will look for. Very uncommonly is, yes, the other things like pheochromocytoma when you have paroxysms, or the patient is lean, having diabetes, etc., and develop hypertension. So then we look for that. And of course, there are others which are very uncommon that only once in a while we get it. So these are the two things we should keep in mind.
Yes. The next question, apologies, yes, sir. You were mentioning? No, I think it was around, sir. So the next question we have is for, once again, Dr. Jabir. Jabir, sir, the question is ARB plus CCB versus an ARB plus diuretic. Is there any evidence to choose patient populations for an ARB plus CCB approach versus an ARB plus diuretic approach? Your take on the same, sir.
Now, there are certain situations where you may prefer ARB plus a diuretic or ARB plus CCB. Look, in an Indian population, I would prefer an ARB plus CCB rather than ARB plus diuretic because of our hot environment, a significant incidence of hyponatremia, unlike in the Western population where they may not have this much, the warm weather. We sweat a lot, we lost a lot of sodium, and the incidence of hyponatremia is quite high. So I would prefer ARB plus CCB rather than ARB plus diuretic. But we have data from majority of the large number of trials which has shown that both these drugs are quite effective. Both these drugs can produce a two-digit reduction in the systolic blood pressure. So it all depends upon which population you are treating. Younger patient, I may prefer ARB plus calcium channel blocker. An older patient, more effective. The diuretic may be more effective. So who is salt sensitive, who is not salt sensitive, we cannot determine it clinically. So by and large, I may prefer a ARB plus calcium channel blocker. And if the blood pressure is not controlled, I'll add a diuretic. Then, of course, then we may change In the morning, we may give ARB plus diuretic. In the evening, we may give another dose of ARB plus calcium channel blocker.
Thank you, sir. Our last question for the day is a question from Dr. Shrutika Singh, and we would like to hear this from all our panel of experts. So Dr. Shrutika writes, a very common scenario seen in practice. If a patient presents with a BP of more than 180 by 100 mmHg, however, there is no evidence of HMOD, no evidence of end organ damage, there is no proteinuria and no other features of HMOD. After initially controlling the BP is what Dr. Shrutika puts it as, maybe she means it in the clinic. Should we start with double or triple therapy for maintenance, or should we just start off with a single drug and then titrate, or what should be the process is what Dr. Shrutika Singh puts forth to our panel of experts.
Look, I'll discuss it first. The current ESC guideline is very clear. As monotherapy is basically for elderly, frail patients where you cannot push in more drugs and you are going for a less aggressive therapy. If this is a young patient, no, then I will definitely, or if it is an old but active person, healthy person, not a frail person, aggressive therapy, start with a dual combination, that is a combination of 2 drugs. Then if not control, go for a triple combination rather than going for a triple combination straight away.
Yeah, I think I agree with Dr. Jabir. Even I will start with the double combination. Of course, no role for single because it's not going to control at all. So that's the reason, at least double. Yeah, the choice will depend. I may prefer a diuretic with the ARB because I will pick up a cons then because he is having such high blood pressure. So I will pick up. So the next visit I'll ask him to get potassium to see has it come down. Of course, before you do all these things, creatinine, all these things we'll do, of course, those things. But I'll use that. And as you told rightly, know the features, etc. Then maybe combination of ACE or ARB with the CCB will be preferred.
To Professor Agarwal, sir, your take on the same.
I will go something differently. There is no doubt that combination therapy, but a patient who has got severe hypertension without a end organ damage, I will try to find out anything recently has happened, and of which non-steroidal anti-inflammatory drug recent intake is one of the very common factor which recently increases the blood pressure to very high level. So in that situation, if that is a history, then probably once after controlling and stopping non-steroidal drug, and if that is the cause, then maybe a dual therapy will suffice and we can avoid triple therapy for maintenance of these patients.
Thank you so much for your views on the same, sir.
And I think, Dr. Parthasarathi, when a patient comes with a very high blood pressure, no target organ damage, then we may have to think whether it is really high blood pressure. We may have to go for an ambulatory blood pressure monitoring. Look for the alcohol intake, other drug intakes. So these are the things, of course, these are the things that we have to look for, why his blood pressure remains quite high. And at the same time, there is no target organ damage.
Wonderful, sir.
So I think before you are ending, I just want to bring a different aspect. We are talking of a medically treated hypertension, but there is a group of conditions which are surgically treated hypertension. Although cause has been covered, but we should not forget obstructive uropathy and a renal stone disease which reduces hypertension and which are surgically treatable.
Right.
So that is a group of hypertension. We always talk of a medicine for control of blood pressure, but a group of hypertension can be cured by surgery also.
Sure, sir. Thank you so much for those views. Sir, we've reached the end of our audience questions, and I take this honor to actually thank each of our esteemed speakers, Professor Jabir, Professor Ganpati Bantwal sir, and Professor Agarwal sir. The three have given their astute knowledge as far as hypertension is concerned from 3 different perspectives, truly making this a hypertension trialogue, if I might call it. And we are having some surround sound from somewhere. Okay, yeah. So we also thank our esteemed audience who have actually joined to be part of this meeting. And we're very sure that the discussions from whatever has been discussed ultimately would empower you to have a better clinical practice and ultimately affect patient care outcomes. Last but not the least, we also thank our technology partners, DocPro, for aiding in the very smooth streaming of this webinar. So thank you one and all. Good night.
Thank you.
Good night,
Thank
sir.
you. Thank you to all the doctors. Thank you to Team McLeod's. We shall end this meeting now. Thank you.